Hello, my name is Alon Kahana, and I'm honored to be asked to participate in this program and to share with you my thoughts on the non surgical management and risk factor control for thyroid eye disease. I have several expired relationships that are not relevant to this presentation. I am principal investigator on clinical trials related to thyroid eye disease with funding from several companies. I will start the presentation by making a somewhat bold statement, which is that, in my opinion, the orbit is the most prone tissue to inflammation in the body. Now, why would I say something like that? Well, if you think about systemic inflammatory conditions, essentially all of them can have a manifestation in the orbit. Obviously, Graves' disease and autoimmune thyroid conditions, but rheumatoid arthritis, IgG4 associated disease, Sjogren's syndrome, sarcoidosis, lupus, scleritis, orbital myositis, Wegener's disease, granulomatosis with polyangiitis, multiple sclerosis, ocular myasthenia, dacryoadenitis, inflammatory bowel disease, Crohn's or colitis, atypical lymphoid hyperplasia. These all can exist in the orbit with associated systemic conditions. The orbit is also particularly susceptible to Molt lymphoma, mucosal associated lymphoid tissue lymphoma, which is a relatively benign form of the disease. And then orbital cellulitis, even inflammation associated with an infection in the sinus, not even in the orbit, can be associated with such a robust inflammatory response in the orbit that it can form subperiosteal abscesses. And then finally, orbital inflammation can be so robust that it creates what appears to be a tumor, a mass, but when you biopsy it, it is strictly inflammatory cells, inflammatory response that is so robust that it coalesces into a tumor-like state. And so, why is the orbit so prone to inflammation that doesn't matter what inflammatory condition can occur in the body, it can have a manifestation in the orbit? Let's start by considering the pathogenesis of thyroid eye disease and its relationship to the endocrinopathy. It's important to realize that while the endocrinopathy and the orbitopathy are related, they are two separate, distinct entities. The endocrinopathy is a function of elevated thyroid hormone. Endocrinopathy can be addressed with medication, surgery, or radioactive iodine. It is essentially curable, and the treatment can be titrated to achieve the desired response. The orbitopathy, on the other hand, is an autoimmune inflammatory condition that does not have a specific on-off switch and is semi-independent of the endocrine status. You can have the endocrinopathy without the orbitopathy. You can have the orbitopathy without an endocrinopathy. And when the two are together, they can have separate paths where the endocrinopathy is getting better because, let's say, you had the thyroidectomy and now you're on levothyroxine and you get normal thyroid function tests, and yet your orbitopathy is continuing to be active and debilitating. So it's important to understand that while the two are related, and we're going to talk momentarily about how the endocrinopathy and treatment of the endocrine condition can impact the orbit, it's also important to realize that the two are separate entities occurring in parallel with some intersection. So what are the risk factors for thyroid eye disease? Number one is unstable thyroid function tests. If the thyroid hormone levels fluctuate, what I refer to as brittle thyroid disease, borrowing terminology from diabetes. If you have unstable thyroid function tests, where sometimes the TSH is too high, too low, too high, too low, constantly changing dosage of medications, that fluctuation impacts the neural crest-derived cells in the orbit in a particular way that activates them to create the environment for thyroid eye disease more likely. In particular, highly elevated TSH activates TSH receptors in orbital fibroblasts to further drive the orbitopathy. So elevated TSH in and of itself is a risk factor for thyroid eye disease, which means that while a range of TSH is normal for patients who do not have thyroid eye disease, if they have thyroid eye disease, particularly active thyroid eye disease, we want to keep the TSH levels relatively low on the lower end of the range. A high TSI titer, and actually high antibody titers in general, reflect a more robust autoimmune environment in which B cells are activated to produce more antibodies, T cells are activated to activate more B cell function, and the antibody titers serve as a surrogate for the overall autoimmune process in the body. High antibody titers are a risk factor for worse eye disease. Smoking. Now, why is smoking? This is a well-known risk factor, but why is smoking a risk factor for thyroid eye disease? There are two reasons. One is the smoke goes into the sinuses all around the orbit, and the chemicals from the smoke can get directly across the very thin bones into the orbital tissues. And the chemicals are toxic, and they cause a toxic reaction in the tissues. That's one reason. And any smoke can cause that. The second reason is that smoking lowers oxygen levels in the body. It lowers the oxygen saturation in the blood. And hypoxia is a risk factor for cicatrizing disease, for scarring. Hypoxic conditions induce hypoxia-inducible factors, and we've published on the role of hypoxia-inducible factor 2 alpha in driving collagen deposition and collagen cross-linking in the orbit. It's actually a similar process to what happens in atherosclerosis, where the hypoxic conditions can lead to scarring in the blood vessels. It's similar to what happens in fibrosis in the lungs of smokers. Smoking is a risk factor for fibrotic processes throughout the body, including the orbit. Radioactive iodine is a risk factor because when the thyroid gland accumulates radioactive iodine, which then causes necrosis of the cells because of the radioactivity, that necrosis releases antigens into the bloodstream. That then drives antibody production in patients who are already producing antibody in response to antigens. That revs up the autoimmune process and revs up both the thyroid condition, so you can get the thyroid storm, and the orbitopathy. Older age, whether it's related to hypoxia or to other conditions, older age is a risk factor. We can't do anything about that, but you need to be aware that the patient who presents with thyroid eye disease at an older age is more likely to develop a more severe fibrotic disease. So you need to be on top of it much more urgently than someone who is, let's say, 24. Vitamin D is a transcription factor. Actually, vitamin D receptor is a transcription factor that belongs to the thyroid hormone receptor superfamily of nuclear receptors. Vitamin D receptor regulates transcription of a variety of genes, including immune system genes. It's a master regulator of the immune system, in particular T cells and especially T regulatory cells. Vitamin D regulates thyroid hormone related genes and vice versa. They both interact and dimerize with retinoid X receptor, and they regulate each other's genes. Vitamin D deficiency is a risk factor for all autoimmune conditions, and we've shown that it is a risk factor for thyroid eye disease. Prolonged hypothyroidism, because it elevates TSH, activates orbital fibroblasts to drive thyroid eye disease. And finally, iodine exposure in patients who have thyroid eye disease can drive worsening of the disease, just like it can lead to a thyroid storm. And we will, in the next few slides, we will touch on all of these risk factors and how to manage them. So first, unstable thyroid function tests. In studies in the lab using zebrafish, our lab has shown that the neural crest cells that form the orbit are not only sensitive to thyroid hormone levels, which are critical in the development of the orbital tissues, but that they are particularly sensitive to changes, to fluctuations in thyroid hormone levels. Indeed, these cells produce their own deiodinases so that they can tightly control the the thyroid hormone levels in the tissues around them. Fluctuations in an adult human of thyroid hormone can trigger these neural crest derived cells to behave in a way that is more embryological, with proliferation and transdifferentiation and migration in the orbit, releasing cytokines that are shared with the immune system. It is critically important to stabilize thyroid functions in patients who manifest any level of thyroid eye disease. As I mentioned, radioactive iodine causes necrosis of thyroid tissue. That's the whole point of it. It destroys the thyroid tissue from within. But when that happens, it releases antigens into the bloodstream, and that drives up antibody production and revs up the immune system. If you're going to use radioactive iodine in anyone who has risk factors for thyroid eye disease, particularly smokers and people who are older, but anyone who is at risk, concomitant steroids can reduce the risk of thyroid eye disease manifestation and progression. The antibodies associated with thyroid eye disease or with thyroid disease are a readout for the severity of the autoimmune process. The autoantibody profile correlates with the severity and presence of thyroid-associated eye disease or thyroid-associated ophthalmopathy. There are many studies showing this. This is one of them from 2004. So this has been known for decades. More recently, studies have shown that TSI is a particularly good readout for the risk of worsening thyroid eye disease in patients with autoimmune thyroid conditions. So I measure TSI levels when I meet a patient in order to better understand their risk for developing worse disease. Patients with very high TSI titers oftentimes do not manifest a particularly good response to IV steroids or oral steroids. And those are typically just a temporary bridge to more definitive treatment. In these patients, I oftentimes recommend a thyroidectomy in order to eliminate the antigen that drives antibody production. Total thyroidectomy has been shown to lead to a more rapid reduction in the autoantibody titers. Here are references of studies showing that thyroidectomy provides a much more rapid resolution out of the autoimmunity than methimazole or radioactive iodine. So patients who are at higher risk or have a higher antibody titers, in my opinion, should be good candidates for thyroidectomy unless they have other contraindications. It is critically important, whether you're using radioactive iodine or thyroidectomy, critically important that you check thyroid levels frequently after your intervention. Not only that, after thyroidectomy, I routinely recommend discharging the patient on 125 micrograms of levothyroxine. It is slightly higher than most patients might need, but it's better to titrate down than to titrate up. By titrating down, I'm starting with a slightly suppressed TSH and allowing the TSH to rise slowly to a level of between 1.0 and 1.5. That's the ideal. The alternative is to allow the TSH to go up to 4, 5, 6, 8, 10, and then try to bring it down by increasing the levothyroxine. And that process leads to activation of orbital fibroblasts and worsening eye disease, or at least a much higher risk of worsening eye disease. Rebecca Bond's group a decade ago wrote, as expected, patients who were hypothyroid at the first follow-up had a longer time period between radioactive iodine treatment and first follow-up compared to those who were not hypothyroid at first visit. Therefore, in a multivariate analysis, duration to first follow-up, and I'm going to say duration to first blood test, remains a predictor of hypothyroidism and a predictor of worse thyroid eye disease. In my opinion, following thyroidectomy, discharge on 125 micrograms levothyroxine per day and recheck thyroid hormone levels in 2 weeks. And then basically every 2 weeks after that until they stabilize. Following radioactive iodine, that first test should be at 3 to 4 weeks, and then every 2 weeks until you stabilize the thyroid function tests. This is critically important to reduce the risk of developing significant thyroid eye disease. Optimal time, Dr. Bond recommends before 6 weeks. After radioactive iodine, I think 3 to 4 weeks is ideal, particularly in patients who are at risk, older, have pre-existing Graves' orbitopathy, may have pretibial myxedema, etc. High antibody titers. Remember, increased TSH leads to activation of TSH receptors on orbital fibroblasts, which leads to worse disease. Another aspect that's really important is trying to figure out why the orbit is so susceptible to inflammatory conditions. And my lab has shown, based on the work of others, that the high retinoid content of orbital tissues may be responsible for the sensitivity and susceptibility of orbital tissues to developing an inflammatory orbitopathy. So one of the things that we know for at least 20 years is that monocyte chemoattractant protein, MCP1, is a key driver of any orbital inflammatory condition through the activation of migrating macrophages and fibrocytes, which leads to release of chemoattractants that bring in T cells and lead to deposition of collagen and cross-linking. MCP1 can serve as a very good surrogate readout to the inflammatory process that occurs in orbits. In my lab, we looked at The levels of MCP1 mRNA, which means gene expression, and MCP1 protein, which is the result of actual translation, in patients with thyroid eye disease versus normal. In all of these patients, adding retinoic acid leads to induction of MCP1 expression. And remember, retinoic acid is a transcription factor. It turns out that this happens through activation of NF-kappa B, which then leads to activation of interleukins and MCP1, especially interleukin 1 beta and MCP1. Therefore, retinoic acid, the presence of it is a risk factor. We can't help that because the orbit is full of retinoids, because that is the visual chromophore. But it may explain why the orbit is so susceptible to inflammatory conditions. Now, interestingly, I told you earlier that vitamin D receptor belongs to the thyroid hormone receptor superfamily of nuclear receptors. It turns out that vitamin D deficiency is an independent risk factor for thyroid eye disease. Now, you may think that in places in the world where there's lots of sunshine, vitamin D deficiency is less likely. That might be true generally speaking, but with modern lifestyle being very indoor based, where people work inside for most of the week, there might be plenty of sunshine outside, but if you're inside in an office building or hospital or wherever it might be, you're not getting sun exposure and you're not getting vitamin D. It's important to test patients who are at risk or manifesting autoimmune conditions for vitamin D levels, and if there is deficiency, to correct it. Now, in the lab, just like we've shown that retinoic acid can induce MCP1 expression, we've also shown that adding vitamin D can actually be protective, can suppress the pro-inflammatory signal of retinoic acid. I think that this is really important. I test vitamin D levels in all my patients with thyroid eye disease, and I make sure that I supplement them for a goal of between 50 and 100 nanograms per deciliter in patients who manifest autoimmune conditions in particular. This is our paper in the ARVO journal IOVS on the role of retinoic acid and vitamin D in regulating orbital inflammation in patients with thyroid orbitopathy. Now, on the role of smoking and older age, as I've mentioned in my earlier slide, hypoxia may be the unifying factor. Why is it that smoking is a risk factor? Why is it that older age is a risk factor? Well, the commonality is that they're more likely to manifest with decreased oxygen saturation in the blood. And so, in collaboration with Terry Smith and Tae-Hwa Chun, my colleagues at the University of Michigan at the time, we looked at orbital tissue and using microsphere technology, looking at elasticity of orbital tissue, looking at collagen deposition and collagen cross-linking and expression of LOX, lysyl oxidase, which is the collagen cross-linking enzyme. What we discovered is that hypoxia-inducible factor 2 alpha gets induced and activates LOX in orbital tissues of patients with thyroid eye disease. This is published work, but to summarize it, just activating HIF2 alpha is sufficient for activating LOX gene for lysyl oxidase, hydroxidase, in these tissues. And we can block that cross-linking induced by LOX by reducing TSH receptor activation. So this also brings in the role of the TSH receptor in orbital fibroblasts. When TSH is too high because you're hypothyroid, it actually induces collagen deposition and LOX expression, and it synergizes with hypoxia. By blocking HIF2 alpha, we can actually reverse some of the fibrosis in the in vitro models. This is all published, by the way. Lastly, patients who manifest with autoimmune thyroid conditions, it's long been known that they should avoid high iodine intake. And that includes iodine contrast for CT scans. If you have autoimmune thyroid disease and you get iodine contrast, that can throw you into a thyroid storm. What is less well appreciated is that this can also manifest in worsening eye disease. So here's an example, and I've seen this many times, but this is a patient who is referred to me for thyroid eye disease. At the time of her referral by her comprehensive ophthalmologist, in order to help me, they order a CT scan with contrast. I don't need contrast. I typically don't need their CT scan either. It's not the kind that I would get for orbital decompression anyway. But by the time she actually comes to see me, this is what she looks like. And this is just in time for the 4 to 6 weeks post-iodine contrast that has been described for thyroid storms. And by the way, she did also manifest a thyroid storm following CT iodine contrast. So my recommendation is to avoid iodine contrast for CT scan, for fluoroscopy, for any of that. If you need a scan with contrast, MRI with gadolinium is fine. But as long as you have a patient who is susceptible and has active autoimmune thyroiditis, they should not be getting iodine contrast for CT. So in summary, it's really important to understand the basic biology of both autoimmune thyroid disease and thyroid eye disease in order to understand how to reduce risk factors for developing the disease and for progression of the disease. We need to reduce risk factors. Radioactive iodine is a risk factor. If you're going to use it, use steroids. Don't use radioactive iodine in someone who already has thyroid eye disease or has high risk factors such as smoking and elevated antibody titers. Unstable thyroid function tests, and especially elevated TSH, is a major risk factor. After whatever intervention, make sure that you test TSH frequently and adjust medications frequently until you get steady state. Don't allow TSH to go up because that will activate receptors on orbital fibroblasts that will drive fibrosis and their inflammatory response. Improved treatments such as anti-IGF-1 receptors come directly out of our understanding of the TSH receptor, IGF-1 receptor pathway. Those two receptors interact to drive the orbitopathy. Don't treat with IGF-1 receptor inhibitors while ignoring the role of the TSH receptor activation from over-elevated TSH because their thyroid functions are unstable. Vitamin D supplementation can be a suppressor of orbital inflammation by suppressing the role of retinoic acid in driving inflammation in the orbit and by suppressing the immune response by increasing the activity of Treg cells that bring down inflammation. We also have, of course, improved surgical tools and techniques for customized surgery, but hopefully reducing risk factors will reduce the need for more aggressive interventions. And lastly, please avoid iodinated contrast in patients with Graves' eye disease or active Graves' disease. Thank you again for your attention. Thank you to Daphna, for inviting me to participate, and I look forward to fielding any questions